clinical usage of iliofemoral approach with ASIS osteotomy. Case example. A patient with a 39-year-old female suffers from falling down the stairs. The X-rays show fracture of lateral compression type injury of the left hemipelvis. The CT scan shows the fracture line involves the anterior part of sacroiliac joint as a crescent fracture type 1. In this case, we use the iliofemoral approach combined with ASIS osteotomy to reduce the crescent fracture. When compared to the lateral window of ilioinguinal approach alone, addition of ASIS osteotomy increase exposure of the sacroiliac joint and medial part of the anterior column around the iliopectineal eminence area. The surgeon operates on the same side of the fracture, and the image intensifier comes from the opposite side. The skin incision of the iliofemoral approach begins at the iliac crest and continues to the anterior superior iliac spine. Then continue distally along the imaginary line between ASIS and the lateral border of patella. After the skin incision, the subcutaneous layer is dissected. At the proximal area, release the external oblique insertion onto the iliac crest, taking care to leave a thick periosteal cuff to facilitate repair. Leave the external oblique fascia attached about 2 to 3 centimeters proximal to the anterior superior iliac spine. This cuff of external oblique fascia will follow the osteotomized ASIS after osteotomy. Elevate the iliacus muscle and expose the internal iliac fossa. Close to the ASIS, beware of the lateral femoral cutaneous nerve running in the subcutaneous layer. Identifying and protecting should be mandatory. Continue to develop the plane between sartorius and fascia lata and detach the fascia lata from ilium about 2 to 3 centimeters at the osteotomy site. The insertion of sartorius and inguinal ligament at ASIS need to be preserved. Now, the osteotomy site is ready to be cut. Osteotomy of the ASIS is performed using a small oscillating saw and small osteotome. Then, we can retract the ASIS medially so the abdominal muscle and inguinal ligament are relaxed. This allows exposure gain along pelvic brim medially at the level of iliopectineal eminence. We can place a retractor on the anterior sacrum. The whole anterior part of the sacroiliac joint and the whole iliac fossa are exposed. In this case, we place a Schanz pin as a joystick through the ilium to help manipulate the reduction of the fracture. External rotation of the ilium wing was done. We can easily visualize fracture reduction through this single approach. Multiple K-wires are used to hold the reduction. The image intensifier is used to confirm anatomical reduction. Collinear clamp is used to compress the fracture gap. The X-ray shows reduced fracture. The pelvic ring and the posterior column are restored and held with collinear clamp and K-wires. The suprapectineal plate is inserted to buttress the fracture. two LC2 screws using cannulated 7.0 millimeter screws are inserted to increase stability. The intraoperative imaging shows good alignment of the pelvic ring. The sacroiliac joint is congruent. The osteotomy site is reattached and fixed back with two lag screws using 3.5 millimeters cortical screws. The surgical wound is closed layer by layer. The postoperative film shows good alignment of the pelvic ring and well-reduced osteotomy site.